All right, I think we can benefit by introducing the councilwoman. We are lucky to have the councilwoman, Mercedes Narcisse, who has been a very strong advocate of Downstate and the health system in general. She came to say a few words and encourage us in the conference. So I'd like to invite you to say a few words before we continue.
I think it's afternoon at this time. No, it's still morning. Good morning. It's such a pleasure to be here in Downstate. My name is Mercedes Narcisse. I represent the 46th district, which is Canarsie, Flatland, Georgetown, Bergen Beach, Mill Basin, Mill Island, Marine Park, Garrison Beach, and Shipshead Bay. I have one of the largest districts in New York City and chair for a hospital committee. Let me tell you a brief story. The last time I was here, because before a hearing, actually, I was here to talk about Downstate, to make sure we keep Downstate alive. And guess what? We scheduled a hearing, me and the senator in the area, and we are able, from 40 million they were talking about, I said, 40 million for us in a Black nation in this area? We need the hospital, we need the services. 40 million is a joke. So let's start talking about the B. After the hearing, we took the hearing, and I received a call that they're moving forward. Just keep quiet a little bit. I said, I'll keep quiet when we get to the B. And then finally, the chancellor sent me an email at 7 o'clock in the morning, say, thank you, council member, we're reaching the B. So guess what? We deserve it, we earn it, and that's what we do as a nation. And I heard it earlier this morning. We have to hold ourselves accountable, whatever the space that we occupy. And first and foremost, I want to say thank you for this panel. Where's Dr. Paul? Dr. Paul took me, not only he took me to Haiti, I had the opportunity to bring my own child that had a vision to become a doctor. And from there, he became an orthopedic surgeon, and I heard the other doctor, Dr. Liverpool's daughter, become, I think, anesthesiologist. So that's mean what we do as a group of folks. I'm a registered nurse, by the way. When we took our heart out there to give the services and respectful services, the children were following, they were listening, and they had that passion and the compassion to serve as well. So it's a pleasure to be with you. Continue doing amazing things that you, wherever you are, amazing thing that you're doing. Keep on doing it respectfully, and the children will follow, and our nation will be better. Thank you so much, all of us together. Thank you.
Thank you. Thank you for all your support and for coming this morning. All right, so I now start the next session. We have 3 speakers for this session, focusing on kidneys. We're going to hear a lot about kidneys, kidney transplant medications, and the like. And we have 3 outstanding speakers. Because of the time issue, I would encourage the speakers to stay within the 30 minutes allocation so that we can finish in an hour and a half, and then be able to take some questions before lunch. All right, so I'm going to go into introducing the first speaker, Dr. Shika Mohitic. She's assistant professor of medicine and also in the Institute of Health Equity Research at Mount Sinai School of Medicine in New York City. She actually finished her bachelor's degree as a health policy. I didn't realize that. So she's actually a health policy expert before she went to medical school. And after that, she did her residency and then fellowships in nephrology. And now she's serving in this capacity at Mount Sinai Medical School. She's a rising star in the field of health equity research and also in nephrology. And today we are very fortunate to have her address a very important topic for us. And her topic is going to be, let's see. Yeah, her topic is going to be, I don't have your topic here, but she will tell us what the topic is. Ensuring optimal kidney health for all, the past, the present, and the future. So, Dr. Mohitic, please welcome to the podium.
Thank you all so much. It's really an honor to be here in community with you all, particularly in such an important, I think, political moment. And I have no disclosures to report other than I have had 2 NIH-funded grants defunded due to their focus on equity and racism. And I am speaking on behalf of myself and not the institutions that I belong to, which include the Bronx Veterans Health Administration. So just to overview, again, I'm a kidney doctor, I'm a health equity researcher. The majority of the work that I do focuses on structural racism and how it has, over generations, created some of the deep wounds that we see. So what are those? Just to kind of overview for everyone in the audience. In short, no matter what kind of underlying chronic condition we see, there are stark disparities. And so when we look at people who have diabetes, the incidence of developing chronic kidney disease among those individuals is significantly higher for Black, Hispanic, Latino, and Native Hawaiian Pacific Islander individuals versus their white counterparts. And this is fairly recent data from 2022. Many of you know, I think one of the most important things that's happened for the field of kidney health and prevention is considering cardiovascular, kidney, and metabolic syndrome together as one entity, recognizing that we need to prevent this very early at stage 1 of disease. What is critical to recognize that even though this term CKM syndrome was coined fairly recently by the American Heart Association, a lot of the preliminary data that we have shows that racial and ethnically minoritized people and men have a greater prevalence ratio of advanced cardiovascular, kidney, metabolic syndrome versus their white counterparts. So we have a huge amount of work to do. And when we look at the kind of trend of disparities over time, we have had people in this country describing and trying to tackle this issue for over now 2 decades. And we are still talking about the same disturbing, stark inequities in the burden of kidney failure in particular. So what you're looking at here is the fact that essentially the prevalence of kidney failure in the United States, particularly in the last 5 years, has not really moved. And Black individuals in the United States continue to have a persistently 3- to 4-fold higher chance or incidence of developing kidney failure versus their white counterparts. And many people have tried to say, okay, there's genetic components, et cetera here, but we know for a fact that that has never fully explained all of these disparities. So what does? It is the care that we have provided, but more specifically, the structural inequities rooted in racism that have created a lot of these longstanding disparities. So this is a disturbing one that we should all pay attention to. Racial and ethnic disparities in the receipt of 12 months of nephrology care with a nephrologist not only did not improve between 2005 and 2015 among people with end-stage kidney failure, but they actually got worse. For all racial and ethnic minority groups. This was outstanding work done in Baltimore. And we know that this is critical because getting earlier access to us as nephrologists often means we can start to plan for things like kidney transplant, prepare people for vascular access, and all of these things earlier. This is a study from Baltimore that I did in part with my longtime mentor, Dr. Ebony Boulware, whose primary study it was. And what we showed is that Black individuals, women, and people who made less than $20,000 a year were less likely to have a conversation about transplant versus dialysis, despite the fact that we know that transplant confers better mortality, morbidity, quality of life, and cost savings. So we have a fundamental issue with the way that we are talking to our patients about certain types of opportunities and benefits and talking to some groups versus others. There's a clear bias in this pattern, particularly in this Baltimore study, but also nationally. And what about this idea of pharmacoequity? So this is the idea that everybody who is eligible for a disease-modifying therapy, so things like SGLT2 inhibitors, RAS inhibitors, GLP-1 receptor agonists, things that we know now are slowing the progression of end-stage kidney failure, we should all be able to get the patients who need these on these at the right time. And we know our systems are unequal, and insurance, for instance, is a huge contributor to the fact that, you know, some of those inequities are unequal. Is this better? Okay, all right.
Saying like the P sounds just
Yeah.
directed above the microphone.
Okay, Okay, all right. So what this study showed was that in a VA system where ideally we should have all of our patients, right, getting the same kinds of access to these novel therapies, even in this VA system, the amount of prescribing of SGLT2 inhibitors, which now really are kind of gold standard care for most of our patients with chronic kidney disease, this is low. But what is very disturbing is that the odds of prescribing these is significantly lower for Black versus white patients, for women versus men, and there are huge variations even within the VA system. This is just a snapshot of what is happening. This is focusing on the VA system, but this same sort of lack of pharmacoequity, so lack of people getting the appropriate therapies at the right time for the right populations, has been shown in multiple studies across people with Medicare and other types of insurance as well. And what about transplantation? So you're going to hear more about this from our amazing colleague, Dr. Watkins, later. But what is, I think, critical to recognize from a general nephrologist perspective, for the majority of people with kidney failure in the United States, getting a kidney transplant from a living donor is really the thing that confers the best long-term outcomes of that kidney, the best cost savings, the best morbidity, the best quality of life. And yet, for decades now, we have seen a dramatically lower odds of receipt of this life-saving optimal therapy, particularly for Black Americans versus white counterparts, but also for other racial and ethnic minority populations. And these disparities have also widened. This is also amazing, groundbreaking work from colleague Dr. Tangela Purnell at Hopkins. And now I've started to give this talk in the context of how do we get this message across to the country so that everybody cares, not just the people directly and most dramatically impacted by this. So I show this slide as a reminder for white Americans. We are not doing better in this country for white Americans versus white counterparts in comparable OECD middle and high income nations. And this is a critical point. So US life expectancy at birth remains lower in the US for white Americans versus all of our kind of counterparts in these wealthier countries, despite the fact that we are spending more in terms of our overall gross domestic product on healthcare. So something has got to change structurally. This is costing people lives, and white people in particular who may perceive that some of these anti-DEI efforts are improving their health, they are not in fact doing that in any way, shape, or form. So we have to correct that narrative. What are other kinds of dramatic contributors to some of the disparities we have seen? Many of you remember that for years we have been using race-based equations to determine people's kidney function specifically. And what this picture shows you is some of the educational material that was given by the National Kidney Foundation to many patients. And it shows that for these three people with the same exact biomarker that we use to measure kidney function, serum creatinine, they would have had a totally different estimation of their kidney function because of the prior use of Black race coefficients in kidney function estimation. This caused an enormous amount of harm, and I'll touch briefly about that later, but what I want you to notice is that one of these people may have never even had a screening for albuminuria or proteinuria, this young man who's 22 years old, despite the serum creatinine of 1.2. And yet the 80-year-old white woman on the figure would have been probably referred to a nephrologist with this kidney function that's estimated at 46. So this is the kind of structural clinical algorithm-based inequity that was rooted in some of the disparities that we saw. And what were the harms of that? Many people in the country spent several years documenting the harms before we saw a national change. This is a critical thing that everybody in the audience should know about because it impacts all of the people that we see. Our patients should be empowered with the knowledge that in the current day and age, and the standard of care should be that race-based kidney function estimations should not be used because they systematically overestimated the kidney function of Black Americans for years. We, based on national studies, an estimated nearly 1 million people would have been eligible for therapies to slow the progression of their disease. 1 million Black Americans. An estimated 70,000 people would have had a kidney function estimation significantly lower, less than 30%, who would have needed education about living donation. And the estimates before the national change in 2021 suggested that removal of this race-based coefficient would have resulted in a median reduction in 1.9 years of waiting for a kidney transplant. So dramatic, dramatic impact of this race-based algorithm. And what is really startling is that it's not new that we're talking about the problem that perceptions of race as a biologic reality have had in our society. Way back in the 1950s, UNESCO said that this idea that race is a biological reality has created an enormous amount of human and social damage, and yet it is only in 2021 that this equation changed in the United States nationally. This happened because of, again, many years back in the Enlightenment era, we created these classification systems around race that really had nothing to do with biology or genetics, but really tried to classify people based on all of these phenotypic characteristics. And this was all part of a very systematically ordered, politically oppressive system created really with an underpinning of racism to create hierarchies. That got translated into science and into clinical algorithms, which we need to continue to combat when we see them. And if that still hasn't convinced us all, right, that race is a kind of a socio-political myth in this United States context that's used to create quite a bit of systematic disadvantage and harm, all you have to do is look at the US Census maps to see how many times we have changed the way that we categorize people in the United States. There was a time period when we didn't even have some of the categories that we do now, and we'll touch on that in a little bit. So what progress have we made? I think this was already alluded to, that in 2000, we, for the first time, due to the very public murders of so many Black Americans, we had almost a revolution of sorts, and we made quite a bit of progress. I think one critical piece of progress, this is a perspective that colleagues and I authored, was in response to the changes made to remove the Black race coefficient. What is really incredible is that not only did the equation change, but thanks to our transplant colleagues and all of the people who advocated nationally, for the first time in US history, this was a restorative policy that was put into place by the transplant organization to make sure that Black individuals who were harmed by the prior race-based equations could actually get their time back. So all transplant centers were mandated to essentially use the new equation and sort of provide time back to all of these individuals who are harmed. And this resulted, at least to date, estimations of nearly 18,000 or 19,000 Black individuals have had wait time modified with a median wait time back for them of 1.7 years. So a big victory and an example of how research can translate to policy with a lot of advocacy from patients as well. Other things that have been great examples of progress, the way that kidney donors' organs were graded also used to be graded based on a Black race coefficient. And thanks to the advocacy and scientific rigor of a number of scientists, that was fortunately removed from the way that these different kidneys are graded using the KDRI. So we now have a more accurate way of doing this work. But we need to continue to forge on and identify other examples of clinical algorithms where race-based medicine has infiltrated and continued to create systematic inequality. There's also wonderful, I think, examples of policy changes that have occurred thanks to the advocacy of patients and many people who partner with the National Kidney Foundation and other organizations. So We have, for example, immunosuppressive coverage now for the long term of a person's kidney transplant for people who have Medicare. This was due to a tremendous amount of advocacy. Now all of us who take care of dialysis patients have to complete a social needs questionnaire for all of those individuals we see. Hopefully, we will have some resources to actually support people to meet their social needs, but even embedding these questions into the CMS forms was a big victory, and we need to do more. But there are still structural inequalities that we have to tackle as well. And we do know that neighborhood conditions contribute quite a bit to some of the dramatic inequalities we see. This is some very early formative work that shows that the neighborhood that you live in and the poverty within that neighborhood is actually associated with a higher risk of kidney failure for both Black and white patients, right, in the United States, though that gradient of impact is higher for Black Americans. We know that when we talk about access to kidney transplantation in particular, no matter where you are in the country, even though this study is focusing on the Southeast, no matter where you are in the country, most social workers, dialysis nurses, and dialysis clinicians will say the biggest barriers to our patients getting kidney transplants, they are largely very similar. Transportation, understanding, a lack of being provided the appropriate information and education about what options are, distance, and socioeconomic factors. So we need structural solutions to address all of this, and we need investment. There were so many beautiful talks earlier this morning about the role of the language that we use in our medical charting, and I wanted to highlight this study. I hope this can be done in some of the nephrology and other sort of subspecialty spaces as well. But this study highlighted that a review of the electronic health record from a Chicago hospital system showed that compared to white patients, Black patients had 2.5 times the odds of having at least one negative descriptor in their notes. This is unconscionable. And we have to hold each other accountable, hold our colleagues and our systems accountable for creating some change. The way that we write about our patients has such a profound impact on the journey that they have, particularly around things like kidney transplant. And back to that point about how we villainize patients, right? In the medical chart, a lot of people say, oh, this person is showing up late to their dialysis treatment. They're not a great candidate for transplant, or they're not a great candidate. They're not adherent. I want you to take note of this quote from a patient who is talking about the challenges that transportation has caused to getting to dialysis treatments on time. Sometimes I have to sit and wait at least an hour, and I have to call and say my ride isn't here yet, which makes me late getting there, which makes me late getting on the machine, and then coming to pick me up then if you're not ready, and then I just wait and wait and wait. This is already after an exhausting, often 3.5 to 4 hours of being on dialysis 3 times a week for the people that we take care of. And 84% of nephrology social workers said that public transport leads to shortened treatments. So when we think about adherence, we have to think about the root cause, and we need structural solutions to fix these root causes. What are some of the other structural inequalities that we have? And a lot of this is rooted in structural racism. We know that the Flint, Michigan water crisis is just one of the many examples of environmental inequity and how that can impact health. There are inequities in access and delivery of care, in psychosocial distress, and the traumas that we are exposed to differentially depending on the communities that we live in. There is targeted marketing of health-harming products like tobacco and alcohol in certain communities. And then certain communities we know have systematically been disinvested in, not only in the periods of redlining that go back to the 1940s in the United States, but in the present day, through present day policies and practices. And then there is a range of other ways in which more sort of upstream factors like voting, housing, education, criminalization and policing, and economic factors impact health. We wanted to study this. I used to live in North Carolina. I lived there for 21 years in Durham, where I was fortunate to be able to do this study with colleagues. We wanted to test this hypothesis that structural racism is fundamentally linked to chronic diseases. What you're looking at in this picture is a picture of redlined Durham from 1950. There are maps like this for every single city in this country, including New York City, that show how housing policies from the 1940s and 50s created restrictions and disinvestment in certain communities where primarily Black and brown people lived and poor individuals lived. And over time, that carried on through, again, lack of resources and other things. And we hypothesized that that would lead to chronic disease prevalence that was greater in those communities. What you're seeing below that is a racially restricting covenant from 1950s in a certain neighborhood in Durham, which says no property in this neighborhood shall be sold, conveyed, rented, or leased in any part to any persons who are not of the white or Caucasian race. So this kind of policy created the neighborhoods that we see in different parts of the country. And we wanted to focus on Durham as an example because it's heterogeneous, it's socioeconomically heterogeneous as well. And we had this amazing ability to conduct this study because we had the electronic health data on chronic kidney disease, diabetes, and hypertension from all of the people who lived in Durham County, who went to Duke Health in our federally qualified health center, and we linked this to all of this socio-contextual data that you're seeing here. So we were able to link it to data on evictions and housing and police shootings and a number of other types of factors. And I want to highlight between two neighborhoods how differently things can kind of pan out. One community here you see is redlined or historically redlined, a community called Hayti, and the other was not. You see how different the kind of proportions or demographics of the people who live in these communities are, but I want you to take particular note of not only the almost 4 times higher median income in the non-redlined community, but also what is going on in these communities. So one has almost 100% of the homes are near fast food stores versus 10 to 15%. And you see even in terms of primary election voting, in one community almost 60% of people are voting in the primary, and in the other almost 12%. And so we hypothesized, again, this is due to criminalizing laws that continue to support felony disenfranchisement and other modes of essentially restricting voter rights. So all of these different policies are manifestations of structural racism and do ultimately have an impact on kidney disease. And that is what we found in this paper, that for every single way in which we conceptualize structural racism with these disadvantage metrics or with specific examples of structural racism, each one was associated with a higher prevalence of chronic kidney disease, type 2 diabetes, and hypertension in this one single county. What about the kinds of products that we know exist in our communities that may cause harm to patients who may not, or people who may not know that they have kidney disease, particularly over-the-counter pain products? I was particularly interested in this question because in Durham, North Carolina, I saw many people just like this gentleman, 52 years old, 14, 15 years of diabetes, high blood pressure, had macroalbuminuria already, said that he wasn't using ibuprofen and all of this, but had horrible back pain. And he said, I'm using these headache powders all the time. I would have to, unfortunately, like many of my colleagues, do dialysis on some of these people who are coming in after this headache powder ingestion. And but this is just one example of something that's on the consumer market, right, that a lot of people are not aware of, non-steroidal anti-inflammatories, where there are differential patterns of the use of these medications, but they may be very harmful in people who have chronic kidney disease. And this particular product, sold as BC Goody and Standback powders, each powder pack has 500 to 1,000 milligrams of aspirin. Very few of the packs have any warning about kidney health on them or any warnings about even cardiovascular health or high blood pressure. And when we started to look in stores in Durham, North Carolina about how they were being marketed, we noticed a lot of different marketing techniques, fast and best, those kinds of words being used, and they're sold at a lower price point than even ibuprofen or Tylenol. And we hypothesized again that this was causing disproportionate harm because people we know of lower socioeconomic status are much less likely to have well-controlled pain than people of higher socioeconomic status, and the same thing for racially minoritized people. So to test this hypothesis, we took data from the Nielsen database, which checks what all kinds of people around the country are purchasing. And we proved our point that these products are not only sold they're more prevalent in terms of their sales in the Southeast, where the belt of chronic kidney disease is greatest, but also that Black households in particular versus white households and households with income less than $25,000 were more likely to have purchased these products. This was a really, really important kind of finding, and what we hope, I know this is not showing up well, but what we hope is that this can lead to some changes in terms of the way that we are empowering people who are consumers about the products that they are consuming. And so we can talk about things like racialized marketing and provide some more consumer protections. I want to close in the last just few minutes here about what is at stake now and where we must go. What is at stake now is grave. I already discussed the fact that race-based clinical algorithms have caused a disproportionate amount of harm in the United States. What you see here is one of the executive orders that is trying to dismantle a lot of the kind of cultural and historic monuments that we have, including at the Smithsonian. This particular sculpture was part of this executive order. And what you see here in this language, right, is highly, highly concerning. This executive order didn't even really make it into much of the media. But what it says is this exhibit claims that this sculpture promotes scientific racism. I already proved that scientific racism exists. And it promotes the view that race is not a biologic reality, but a social construct. How incredibly disturbing is this? So we have to counter these harmful narratives and show examples that for decades now we have proof that, again, race and ethnicity is a flawed surrogate for a number of other factors, and we have to move toward precision and understanding genetics and really disentangling racism from race. And I've already showed you again that we have examples from the census that, this is a lot of made up stuff that we're doing. And another great example of how this was embedded, right, for years. Look at this 1947 article where they're saying sickle cell anemia is a race-specific disease. If we really thought that, we would not even be able to detect sickle cell trait or sickle cell anemia in many millions of people in the world who are also impacted by sickle cell trait and sickle cell anemia who live in, for example, the Middle East, right? So it was scientific discoveries that showed that this is a geoevolutionary adaptation that resulted in this gene frequency. And just like that, we have other new kind of genetic discoveries in kidney disease. It is APOL1, specifically a particular protective genetic variant for African sleeping sickness. There was a time period when, people were saying, okay, we should only focus on people who self-identify as Black for testing for this. But in fact, there are many people who self-identify as Latino or Caribbean American who have APOL1 specific traits, and Native American, who, if we had just a race-based idea of this disease, we would really be causing harm and missing screening and critical opportunities to provide them care. We also need to understand some of the second hits that accelerate disease, such as structural racism. And that's actually what one of my studies was trying to test. But we got this notification from the current administration that this award is related to DEI and it's antithetical to scientific inquiry. This is the language that many of us who've had defunded NIH grants have received. As you can see, it is incredibly painful to read these words. It is damaging, it is untruthful, and I have a patient and community stakeholder board that was part of this particular study, and the night that we got this termination notice, we all read this together. And every single patient on that board said, this reads to us like we do not care if you die. So what actions do we take now? We have to have hope. And I think we need to provide more counter narratives to those who continue to say that there is a fixed pie. This equity is not a zero-sum game, and this book does such a beautiful job of, I think, highlighting this fact that, again, zero-sum thinking is causing a lot of harm. The fixed pie fallacy thinking is causing harm, and when we ensure equal opportunities and resources for those who are the most disadvantaged, we improve systems and outcomes for all of us. The second thing is we have to continue to connect the dots. So as we see Medicaid funding cuts, it is not just those of us here in this city who will be impacted, but many of our colleagues in rural parts of the country where, again, the kind of largest populations are not necessarily racial and ethnic minority people. Rural hospitals will shut down, so we need to start building coalitions with people around the country. We need to start being very clear about what these cuts are going to do for the people that we take care of. So this is a slide that is very specific to people with kidney disease. But just a reminder that before dialysis, nearly 1 in 3 people who have kidney disease rely on Medicaid before dialysis. So this will be devastating. And then we need to start to cite the facts about what this is costing us in dollar amounts. This was a really important, groundbreaking study showing that the estimated total burden of racial and ethnic disparities in healthcare cost a total of $451 billion nationwide, with a disproportionate burden, again, on all racial and ethnically minoritized communities. We have to, in our charts, start to do better with the way that we're documenting. So every time we're writing in a medical document, we should be asking ourselves these questions. Are my reinforcing stereotypes? Is this blaming the patient? Is there extraneous information? Is it biased or harmful? And how would my patient or loved one feel if they read this? We need to continue to support efforts such as Medicaid expansion and waivers that offer opportunities to fund community health workers. We need structural solutions for these community health workers to help us do our job and the critical job of navigating patient journeys better. These are just examples of things that, again, community health worker interventions can really help us address each of these domains. And then we need disruption. This is actually a former co-fellow of mine who started this program in Michigan, where they have people in the community taking medications to patients who need transplants and driving them through, again, faith-based organizations and partnerships, driving them to the transplant center to get their initial evaluation appointments. So even when these NIH funding cuts happen, we can still do the work we have to do. We must do the work that we have to do. And then partnered advocacy. This is me with many of the amazing patient community board members who are part of our defunded study, all of us speaking with members of the Senate Help Committee, talking about the devastating harm of that decision to terminate this study, among many others. So we have to partner to center and elevate the voices of our community and patient partners. I'm going to stop with that. Thank you all so much again for having me. I will. I wanted to leave with a quote, and lately I've been really, when people say that, there's voiceless people, or we're here to, speak on behalf of the voiceless, I think this is a reminder that there's really no such thing as voiceless people. There are only the deliberately silenced or the preferably unheard, as Arundhati Roy said.
Thank you.
Thank you.
Okay, our next speaker is a protector of kidneys. His name is Dr. Jesse Rang. You can find his profile in the packet, but he's an associate professor of pharmacy and in the division of nephrology at Howard University College of Pharmacy and Medicine. He did his doctorate in pharmacy at the University of Maryland, and from there he went to GW to do his clinical pharmacy. And then after that, returned to Howard to be a clinical pharmacist, specializing in nephrology pharmacy and protecting the kidneys and making sure that nobody's prescribing anything that damages the kidneys. So today he's going to share his experience, and his topic is going to be equity in kidney care, reducing nephrotoxin burden, and improving acute kidney injury outcomes. Thank you for coming.
Hello, everyone. Thank you so much for having me here. So we learned a lot from Dr. Mahatich about what have been done at the higher up. So let's see what we have been doing from the ground up as well. So again, my name is Jesse Rong. I'm a associate professor and kidney pharmacist at Howard University, and I practice at Howard University Hospital. So I have nothing to disclose. The objective of the talk today is to describe the impact of nephrotoxin burden and discuss strategies to mitigate the risk of acute kidney injury and improve outcome among African American patients. So in terms of, let's skip this one. I know we're short on time. So let's start with a case. We have a 45-year-old male, Black patient presented with shortness of breath, acute respiratory symptoms. He was later diagnosed with severe community-acquired pneumonia and now admitted to the MICU. He, unfortunately, has a following past medical history. He has poorly controlled hypertension, poorly controlled diabetes, and has a heart failure with reduced ejection fraction. So compare our patient to an otherwise healthy white man who is admitted to severe pneumonia as well. So you can see that at the hospital, Black patient will receive the treatment for pneumonia. And on the other hand, how do I get the, okay. So at the hospital, Black patient will receive treatment for community-acquired pneumonia. And on top of that, Black patient will also receive medication that the patient came with pre-hospitalization with diabetes treatment, hypertension, and diabetes. As opposed to a white patient, they only receive treatment for pneumonia. What if I say that many of these medications potentially can be nephrotoxic? Many of the heart failure medication can behave in a way that can damage the kidney. And some of the medication that we treat the infection in the hospital can potentially be nephrotoxic. Who will more likely to develop acute kidney injury in the hospital? Black patient versus white patient. That's what we're going to discuss today, and how we can mitigate the risk of acute kidney injury among patients that we see in our practice. In terms of prevalence of AKI, there is a huge study published in about less than 10 years ago using KDIGO AKI definition. Worldwide, statistically, the incidence of acute kidney injury happens in about 20% of patients who are admitted to the hospital, so about 1 in 5 patients. At our local data at the HBCU hospital, it's about 1/3. It's about 34% of patients develop hospital-acquired AKI, which is, you can see that it's higher than the global statistics. Drug-associated AKI has been known as a leading cause of acute kidney injury. No matter what type of studies that you do, prospective, retrospective, it always has been seen that as a 3rd or 5th leading cause of acute kidney injury. So drug is important that can drive bad kidney outcome in the hospital. And unfortunately, we also have seen the rising incidence of acute kidney injury in our community. Over the past 2 decades, there was a dramatic rise in AKI, particularly in our country. So you can see that no matter what data set we use, USRDS in 2017, 2018, and read the most recent data in 22-23, the incidence of AKI is higher, and it is higher among Black patients when you compare with patients of different races. And this is actually consistent with our local data, where about 1/3 of patients who are admitted to our hospital develop acute kidney injury. So why is that? So Dr. Mahatich also alluded in such a nice way about why and how structural racism have placed patients into at risk of developing acute kidney injury or chronic kidney disease. So I'm not going to go into a huge detail, but for our perspective, I just wanted to paint a picture that patients who came to the hospital, if they're African American or Black, they are more likely to have several comorbid conditions, several pre-hospitalized risk factors that they came in before they come to the hospital. And this could be the reason why they are more likely to develop acute kidney injury in the hospital. You can see here in this kind of BC diagram that there are several things that can put patients at risk of acute kidney injury. Once a patient set foot in a hospital, whatever treatment that we prescribe to the patient, surgery, patient can develop cardiorenal, hepatorenal, ischemia, hypoperfusion. The patient can develop sepsis. If the patient is older or having pre-existing CKD, everything can compound and put patients at risk of acute kidney injury. And once a patient has developed AKI, decreased drug metabolism will put nephrotoxin a little bit more pronounced, and dose and medication will have a higher effect on the kidney function. And I wanted to show here a little bit about, there was a lot of conversation over the past, technology and me are not going together well today, about Black race and acute kidney injury. So like Dr. Mahodij alluded earlier about APR1 gene mutation. So APR1 gene mutation, it was discovered in the 90s, recessive gene, what she said about it was discovered as a protection from sleepy sickness syndrome in Africa. There was two variants, specific variants that are associated with increased kidney failure risk, G1 and G2. So if the patient harbor G1 and G2 genetic mutation, they will be at a higher risk of kidney failure, and G0 refers to low risk that does not contribute to kidney failure. Who are at risk of this kidney failure high risk. So you can see here that the area in this dark purple represent the patients who are at higher risk of harboring G1 and G2 genetic mutation. And during the global migration during the 17th and 18th centuries, individuals who have this genetic risk had traveled out and then come to the United States, the Caribbean region, and they may or may not know that they have had this genetic mutation. However, it's not everyone that with this gene will develop a kidney failure. You need additional exacerbating risk factors serving as a second hit or a third hit, like what she mentioned. What we know so far is that second hit can be COVID, HIV, inflammation that could serve as second hit, and this second hit will propagate patient from having a dormant kidney function to a full-blown kidney failure. However, you can see on this panel that even patients or individuals who were born with genetic risk, they can grow up to have a normal kidney function, or they can develop a worsened trajectory by developing kidney failure as well. This is something that we also have not yet to discover. What are additional second hit that we don't know? What are some structural racism? What are some structural abnormalities that propagate African American patients who have kidney genetic risk that put them into a development of kidney failure faster than white counterpart? We have known that patients who have people who harbor APR1 genetic risk, coupled with sickle cell disease, they have a worsened kidney outcome than people who don't have APR1 risk. We also know that APR1 coupled with COVID-19 put the patient at a higher rate of dialysis initiation. We also know that APR1 coupled with HIV can also exacerbate dialysis initiation. So as a pharmacist, what we don't know is that maybe we need to rethink about what medication that we expose to the kidney of the patient who have a genetic risk. Should we see some medication? Should we think of them as a second hit? That is a question that we may need to ask ourselves when we prescribe medication to our vulnerable population. I want to track back and talk a little bit about trajectory of kidney disease. So we all know that once a patient develops acute kidney injury, it is the time that they have an abrupt decline in kidney function. And they, by definition, acute kidney injury is about 7 days. And after that, the patient will be in the phase called acute kidney disease, or AKD. And after 90 days, the patient will be in the phase called chronic kidney disease, or CKD. So what we need to target is that once the patient develops acute kidney injury or develop AKD, what can we do to prevent them from progression to CKD? So KDIGO, which is the governing, not the governing body, but the body that developed guideline for us to treat kidney disease, developed a practice guideline in 2012 for the management of acute kidney injury. So KDIGO suggested having a treatment care bundle for all patients, even who are at risk or develop AKI stage 1, 2, and 3. We can now see that across all stages, whether the patient is high risk or stage 1, 2, and 3, they recommended us to discontinue all nephrotoxic agents when it's possible. However, as we all know that to say this, it's kind of easier to said than done, because we all think that every medication we prescribe has an indication, right? So what can we do to rethink that concept, and what can we do to ensure that medication that we prescribe is not nephrotoxic? So let's talk about that. In terms of drug-associated AKI, the old term that we have learned over the past decade is pre-renal, intrinsic renal, and post-renal, right? So this is an old term. We have a newer term which is published over the past few years. So this new term, it is created because nephrotoxin can cause AKI by more than one mechanism, like NSAIDs. It can cause pre-renal, it can cause intrinsic renal, it can cause post-renal, right? So this is a category that has been proposed, and I really like this category because it shows the movement between categories, and it can be slowed down, or it can be reverted back based on a modification of risk factors. I'm not going to go into the detail of each category, but basically what I want to show is that AKI is a syndrome, right? And AKI is propagated by risk factors, right? So if we can modify the susceptibility to risk factors, we can potentially slow down the movement between categories. So if a patient were in the stage that has a mild AKI, if we modify risk factors, basically nephrotoxin, we may be able to stop the movement from the less severe to non-severe category. And that is what we can do to improve the outcome among African American populations. And so this slide talks about agents, right? We talked about, we gotta stop this drug, But I wanna point out that it's not just an agent. Duration also matters. This is a large multi-center, multinational studies that was conducted in Europe. So this one is conducted in medical ICU across Europe. It's published from French ICU physicians. They were looking into the incidence of AKI and nephrotoxin burden. The burden is coined first in this study and was quantified by quantified by drug times number of days. So it shows that the longer the patient is exposed to nephrotoxin, drug times day, the higher the burden, what is associated with higher stages of AKI and worsening acute kidney injury. So it shows to us that it's not just the agent, it's also the duration that also matters. So going back to this patient again, you can see that if the Black patient who is admitted to the hospital with a lot of medication that can be nephrotoxic compared to non-Black patients who admitted to the hospital with just no comorbid condition, nephrotoxin burden among Black patients is higher, and that is probably contributed to the high incidence of acute kidney injury in the hospital. So what can we do? What are some strategies to reduce nephrotoxin burden? Number one, the first thing I want to suggest is the use of novel stress biomarker. So the concept of stress biomarker is not new. It's been around, I would say, more than a decade. We've been talking about the use of biomarker to diagnose, to prevent, to early detect patients who are at risk of AKI, but the adoption of this stress biomarker has been low. So the stress biomarker is going to allow us to identify patients who are going to develop future acute kidney injury. Basically, what we do currently is we wait for serum creatinine to rise. Once it's rising, we say this patient is having acute kidney injury. But serum creatinine lags behind true GFR, and it's not really a good functional biomarker to detect or to prevent acute kidney injury. So if we have a marker, once a patient has an insult from medication, the kidney will be in stress. And after, if the kidney is in stress, if we have any biomarker such as TIMP2, IGFBP7, or the commercial name called NephroCheck, if we can quantify this stress molecule in the urine, we might be able to identify patients who are at risk and have an intervention to mitigate those risks or change the trajectory of the acute kidney injury. And the way that we can use, acute kidney injury, yes. However, the uptake of these kidney stress biomarkers in medical literature has been focusing on surgical population, cardiac surgery, abdominal surgery, perioperative care, critical care, sepsis, or among pediatric population. We have very limited amount of literature that include patients who identify as African American or Black. And I think what we can do is to increase awareness and uptake of this stress biomarker. And the way that we can integrate this biomarker is to use that within the context of nephrotoxin stewardship service. So KDIGO issued a CKD guideline in 2024 and suggested a drug stewardship by defining them as an effective, safe, and sustainable use of medication by all staff and physicians, encompassing the whole cycle of medication use. The goal of nephrotoxin stewardship is to prevent AKI occurrence, prevent worsening of AKI, and prevent CKD prevention. The service, what we can do to reduce the burden is to review patient history, estimate kidney function, utilize novel stress biomarker for early detection and early intervention, and modify therapy and to change the patient's trajectory. And like I put in here in a quote unquote, is that we should be able to appreciate the effect of APR1 mutation. Currently, the genetic testing is also one of the mission from American Society of Nephrology Kidney Health Initiative. Even though currently we don't have any medication in the pipeline that is FDA approved to treat, all the agents are in phase 2 and 3 right now. But the ASN and KHI has a mission to improve their awareness of APR1 mutation, improve the testing, and improve the overall knowledge of this APR1 mutation among African American communities. We might need to think about how we use medication among our patients who are at risk. Maybe we need to think about medication as a hit, as a second hit or a third hit. But what we can do is to control and limit second hit. If we know that HIV serve as second hit, we might need to educate our community to use PrEP, have knowledge on how to use PrEP, and also COVID vaccine, because COVID can be served as a second hit. And after we do all this, we might be able to modify therapy to change the trajectory of kidney disease. So in summary, Black patients are at risk of AKI from multiple etiologies: baseline, pre-hospitalization risk factors, higher medication burden that are nephrotoxic, and potentially genetic component, which is APR1 gene mutation. There are several strategies that can improve the care of Black patients in the hospital, recognize overall nephrotoxin burden, utilize novel kidney stress biomarker, and potentially utilize nephrotoxin stewardship at the hospital that you're working at. And thank you so much.
Thank you very much. Our next speaker is Dr. Anthony Watkins. Dr. Watkins is a surgical director at the Kidney and Pancreas Transplant Program at Tampa General Hospital. Following medical education at University of Tennessee College of Medicine, he did his residency in surgery at UMDNJ, which is now Rutgers University. After that, he did his transplant surgery fellowship at Columbia, and then stayed in the system on faculty at Columbia, Cornell, and at some point also at NYU, but now serving at Tampa General. He's a rising star in health disparities and access to transplantation. He's chair of the American Society of Transplant Surgeons, DEI committee, and also the American Society for Black Academic Surgeons as well. So you can see that he's doing a lot of work around the country around access to care, health disparities, and the like. So we are very fortunate to have him today present to us, Bridging the Gap, Addressing Disparities in Access to Kidney Transplantation. So welcome, Dr. Watkins.
Good afternoon. I should just make the comment that the DEI committee for our Transplant Society has changed its name, as to no surprise, but the work still remains the same. Thanks for the planning committee for providing this invitation to talk, and it's good to see some familiar faces where I did a couple of medical missions to Haiti, which really profoundly impacted my understanding of global healthcare access. Here's the overview of the objectives today. The good news is the previous presenters really did a great job of kind of laying the groundwork, so I can kind of focus on the transplant stuff, which could hopefully get you to lunch a little bit sooner. So we're pretty much familiar with the stages of kidney disease. I really placed this slide up to just really emphasize that a patient cannot get listed for a transplant until they have a qualifying GFR of 20 or below. And this is very important in regards to referrals to transplant centers, so we can get patients listed. And ideally, we like to pursue preemptive transplant, which is basically a patient getting a transplant before dialysis even is initiated. Obviously, that's a challenge with the limited supply of kidneys. When we look at the primary etiology of end-stage renal disease for the adults that are on the waiting list, historically the two most common causes have been high blood pressure and diabetes. It's important to note that if you notice over the past decade, hypertension-related listings have been on the decline, whereas the diabetes listings have increased, going from roughly 35% in 2012 to 40%. So I think this really points out and reiterates the need for targeted prevention and early intervention as it relates to diabetes to decrease the burden of end-stage renal disease with those patients. We've already heard about this multiple times. I will revisit it later in regards to its implications on transplant and how we have to kind of address this. The main point being, when individuals have the two variants, there's a roughly 15% increased risk of kidney disease. And so, as I mentioned, there's some challenges in our community in regards to transplant. This, again, another image that you've seen before, end-stage renal disease broken down by race, African Americans / Black, Native Americans, and Hispanics with the top prevalence. And really, when you look at the disparities issues between these three groups, there's a lot of significant overlap. And then, since I wanted to kind of comment on the global implications when relevant, since this, we're also talking about local and global populations. So the dark blue and red have the highest incidence of end-stage renal disease in the world. So can't really see Taiwan, but that's one of the red countries. But obviously America, you see, has another higher incidence of end-stage renal disease, whereas Asia and parts of Europe is a little bit lower. The reporting is not that robust throughout the world as well, so there's some underreporting represented as well. We're aware of the implications of the social determinants of health, where we live, access to healthy food, quality insurance. We know these things, that how they affect health and outcomes. And as previously mentioned, so Durham was used earlier. This is Richmond, Virginia. This is the redlining from 1937. There's a really great article in NPR, which really showed, again, the link between historical disinvestment in these, certain parts of the cities in regards to mortgage lending, and how when you take that same redlining and apply it to current day or modern day Richmond, you see that those areas that are in red, those individuals have lower life expectancy, higher poverty, higher incidence of diabetes and high blood pressure, and the percent minority is 99%. But it goes a little deeper than social determinants of health. So this paper here is a single center prospective study, It looked at 1,000 patients being referred for transplant. And what they indicate, and they were kind of looking at which demographic and social factors predict the likelihood of receiving a kidney transplant. And what this paper and in many others have highlighted is even when you adjust for social determinants of health, Black race, right, is a poor indicator for being able to receive a kidney transplant, particularly a living donor transplant, which I'll talk about why that's more advantageous. So dialysis is an inadequate, replication of the kidney's function. It only performs about 10% of kidney's function of a person's kidney function, low survival rate, low quality of life, a lot of negative impacts. And transplant is the gold standard. Ideally, everyone who's a candidate for a transplant would get one. They have improved survival, improved quality of life, and it's actually cheaper from a healthcare expenditure point of view. However, again, we in our community, until things like xenotransplantation and perhaps more living donors are possible, we're going to still struggle with our ability to transplant the patients that are in need. Now, when you look at the kidney transplant waiting list over the last decade broken down by race, you see the exact opposite of what you would anticipate based on the prevalence of end-stage renal disease. So white patients make up the majority of the people getting on the list for transplant, followed by Blacks and Hispanic. And then when you look at the kidney transplants performed during the same time period by race, again, you see white patients are the ones receiving the majority of transplants. It is worthwhile to note that we are seeing an upward trend for the Black and Hispanic patients, which is good. But Native Americans, which also have a high burden of this disease, as you can see, has been very flat. So there's still a lot of efforts that need to be made within that community as well. And then again, from a global incidence of kidney transplant, just to comment, the light blue is the number of transplants per million population. So you see America, Canada, and Australia have the highest rates of kidney transplant, whereas parts of West Africa, South America, and Asia have lower rates. So shows that from a global perspective, there's still some challenges with the healthcare infrastructure, organ availability, and emphasis on transplant to address that need globally. So I do want to spend a little time on this image here because the barriers to kidney transplant are significant. To get listed for a transplant is a very complex process, and therefore the higher the complexity of something, the more likelihood of attrition from that process. I'm gonna try to use this pointer. But if you look to your far left, first, and there's three separate entities. There's structural barriers, there's institutional, at the center level, and there's actually individual barriers that kind of play a role, again, in the attrition from this product. Oh, there we go. I think I figured it out. I'm sorry, yeah, this little ball here. Okay, so here you see screening, right? So this is, look, as much as I love the transplant patients, preventative strategies are critical, right? And so screening for early disease, lifestyle modification, these are important within the community. And as we mentioned, this is kind of where the social determinants of health can kind of come into play, access to quality health care. Then as the kidney disease progresses, someone has to identify these patients and refer them to a nephrologist. So then if that's successful, then when certain nephrologists are seeing patients, there's challenges at that level as well, whether it be implicit bias, communication barriers from a cultural standpoint, which lead to a high rate of attrition at this point. There's even some nephrologists that, make false assumptions in regards to a patient's candidacy for transplant, be it their weight, comorbidities, et cetera, that still actually play a role as well. And then if the patient is referred to a transplant center, then there's a lot of issues at our transplant center level. There's a lot of subjectivity in regards to adequate social support, and perhaps some cultural barriers between a provider and a patient that can result in attrition even at that point. And then finally, people who even get waitlisted for a transplant, either A, a large percentage might die on the waiting list, or B, the majority are getting deceased donor transplants, which have, the worst outcomes or inferior outcomes in comparison to a living donor transplant, or even getting a transplant before dialysis is started. So this complex process really highlights a unique, I think, situation in medicine, and why some of these disparities can be magnified within the transplant community. So now, 8.1 in regards to kidney transplant, the implications are as such. If we have an African-American patient who wants to donate to someone as a living donor, there's currently no standard guidelines in how that patient should be approached. So there's extreme variability in the transplant centers and how they approach this, but what we tend to uniformly do is, at least at minimum, we educate the patient on the potential risk with having two variant mutations in this gene. We really strongly advise testing. And then if the results are positive for the two variants, then it's a question of, well, what do you do? Because there's still some unknown answers, right? There's the other hits that are required. And there's some centers that, hey, if you have two variants, you're not a candidate to donate, which then can kind of come into a challenge when it comes to patient autonomy, right? And particularly when you're dealing with a group that already has a low donation rate. So what some centers do, like my current center, is we do it a case by case. If someone has two variants, and it's kind of like, well, how old are they? Are they still any evidence of kidney disease? But the point being is, these are kind of issues that contribute to the low living donation rate amongst this group that I'll talk to you about. But what this figure depicts is, what we do know is that the risk is related to the donor who's donating and within that kidney, meaning if you look at the top figure, if I have a high-risk donor who has the two variants and we transplant a patient with that kidney, what studies have shown is there can be a decreased allograft survival in that scenario. Whereas in scenario B, where the donor is not high risk, but the recipient is, those outcomes appear to be okay, no apparent impact on allograft survival, which basically means it's not a circulating, phenomenon, but something that's inherent within the kidney. There is a multi-center study called the Apollo that's anticipated to end later this year, and it's really focused on further elucidating, what the outcomes are in regards to patients with these mutations. And hopefully when that data comes out, then we'll have some stringent guidelines so we can ensure patient safety, patient autonomy, and optimizing kidneys safely for people who are in need. So real quick, I want to kind of point out the difference between living and deceased donation. So if you look at, in transplant, we look at patient and graft survival as outcomes 1, 3, 5 years. If you look at the outcomes between the two, living transplants perform much better, right? There's, when people suffer brain death, there's injurious toxins that are released that make those organs inferior to people who are alive. So I hope all of you are organ donors. But this is one of the reasons why we, try to encourage as much living donation as possible. In addition, the average waiting time for a transplant on the deceased donor list is like 3 to 5 years, and that depends on where you live. New York has some really long waiting times, and it also depends on your blood type. However, it's simple to say that if someone presents to a transplant center with a donor, as soon as that donor and that patient is medically cleared, we can do the transplant. Whereas if you don't have a living donor, you then go on a list and you're waiting years and years where the dialysis, your diabetes, et cetera, continue to impact your overall health and can impact the outcomes of transplant. And with that in mind, as you can imagine, if someone has got to go on a list and wait for years, the odds of them having a, quote, preemptive transplant before dialysis is pretty low. It essentially can primarily happen when you have a living donor and you're obviously referred to a transplant center timely. And then finally, the living donor transplants tend to work immediately. I tell people when we're on the operating table before we even finish, the kidneys making urine, whereas the deceased donors can have something called delayed graft function, which is when patients get transplanted, but they still are on dialysis for a short period of time until that kidney fully kicks in, and that can be anywhere from days to sometimes even weeks. So that's kind of a big overview of the living versus deceased donor transplants. And then there are significant disparities in living donation rates. Black patients are 59% less likely to have a living donor than white patients, as this figure depicts. So there's still a lot of work that needs to be done within our communities, advocating for living donation. There's various factors that I have listed here that come into play, including medical, mistrust, which is still very relevant. And I'll talk to you about, some strategies transplant centers can take to mitigate that issue. So now I want to shift to kind of, what have we done to kind of address this? And I'm going to divide this between this one example, which is kind of one of the broader examples from the transplant community. Then I'll talk about some community efforts that, outreach, and then I'll talk about something from the transplant center perspective. So there's been multiple reiterations of how kidneys are allocated. I'm highlighting one that was done in 2014, but there has been a subsequent revision in a different way that's actually impacted equity in a negative fashion from early data, but that still has to be teased out. But importantly, this allocation change was important because one of the first things it did is, historically, patient comes, gets evaluated, gets lifted for transplant, their waiting time would start then. As you could probably imagine, there's a significant amount of delays that tend to affect underserved communities more than others, whereas it's very common to have a patient of color come to get evaluated for transplant, and they've been on dialysis, for 5 years, right? And so historically, that time was shot, whereas after this revision, 2014, whenever a patient gets listed now, it's retroactive to when they started dialysis, which is a great move in the right direction. This revision also prioritized highly sensitized patients. These are patients who've had pregnancies, blood transfusions, or previous transplants, and it's very, very difficult to find an organ that they're compatible with. This system really prioritized them, so instead of them only getting local offers, they now get national. So someone can get listed tomorrow, and even if they've been on the waiting list one day, if they're super sensitized and the organ becomes available in California, it will go to them. And this, unfortunately, this affected underserved communities a lot more. So that, again, this was another important step. And then expanded regional sharing for high priority candidates. So ultimately, what the data shows is that all of these steps from this allocation revision resulted in a roughly 25 to 30% reduction in the Black versus white patient wait time gap. So that was a move in the right step. About the EGFR, the previous presenters kind of talked about that. This is yet another example. But what I'll do is I'll show you what we did at our center. And I think one of the challenges with this, to my understanding, this is a policy change, but it required a lot of work, which is what this outlines. And my concern has always been, well, how many centers took that time and effort? At the time we did this is kind of a little dated, but we had 839 patients on the list, 236 were Black. So we had to send letters, call, to try to get their historical lab data so we can recalculate, their EGFR with a race-neutral calculation. We adjusted 138 as out of 236 patients, so that's a lot of adjustments. We added 300 years total of waiting time, 300 years. The median days was 619, and one patient had 8.5 years added. They could have been transplanted 2 or 3 times, right? And at the time of this, we had transplanted over 50 patients. So, this is a move in the right direction, and, it goes without saying that there's historically a lot of patients who did not benefit from access to transplant because of this, but at least, again, progress. I'd be remiss to not mention the work of Dr. Clive Callender, a Howard transplant surgeon, started MOTEP back in 1991. This is probably the best example of a local effort that spread nationally to kind of educate, our community in regards to the importance of organ transplantation, provide it in a way where there's ability for trust to be built, there's the shared experience, so people can understand, the realities of this. And so, I've always looked at him and looked up to what he was able to do with this program and how it's, had an impact on educating our communities in regards to transplantation. And then finally, Northwestern Medicine really pioneered the approach of using culturally competent programs within the transplant center. And what they did is they created a Hispanic program and then later created an African American program where you have a program champion, right, who's running these efforts, and they essentially have created a culturally congruent team. So what that means is you have a transplant surgeon, ideally all this transplant surgeon, nephrologist, social worker, transplant coordinator, who are racially congruent with that ethnic group. So now you have the ability to foster trust, right? These individuals have a shared experience, so that can break down some of the barriers that exist. And then you have a dedicated social worker who can spend the extra time to work with these patients. This is, this image has the program champion as big. I think the social workers should be the biggest, because oftentimes it's these elements, as mentioned before, transportation, have the right social support, that it's, people are very quick to dismiss as they don't have adequate psychosocial support, they're not a candidate, when that's not really the case. You just need someone who has a little bit more time to dedicate to help and assist them. And so, and then finally a health literacy coach to obviously improve their health literacy. But they started these two programs and they were extremely successful. So what we did in Tampa is we started a Hispanic transplant program, and that's been relatively successful. But when we started the ATAP program, is what it's called, when we set forward to start it, because as mentioned, I'm also one of the individuals who had an NIH U01 grant, which is what this was, that got defunded by the administration. But our goal was, and still is, we're trying to find external funding, but is to replicate what Northwestern Medicine did and then do it in a research capacity. So we're not just, impacting the community that we serve, but we're providing the blueprint through research mechanisms so other transplant centers, can also do that as well. And essentially, it's, what I tell people is these programs aren't for all Black people or all Hispanic people. There's a strategy involved where you want to kind of identify those individuals who are at high risk. Like if I needed a transplant, I wouldn't need this. But for those individuals who might have low health literacy, low social support, we put them through this program. They come. I'm fortunate to have myself, a Black nephrologist, social work, transplant coordinator, and they see these individuals. And then we kind of do this in a randomized way to show that we also can duplicate what Northwestern did, and then provide that blueprint to the community. Now, the elephant in the room is that diversity in healthcare is a challenge. 3 to 4% of physicians being of color, so not every transplant center has that ability. But I do think there's mechanisms like virtual health visits, et cetera, to kind of play a role in that. So hopefully I saved a little time. But in summary, there's significant disparities that still exist in end-stage renal disease and kidney transplant access. There's been some policy reforms that have been helpful, but it's important for us to continue to work together to make the necessary changes so that we can improve equitable access to transplant for our patients. And there it is. Thank you.
Okay, so we're supposed to have lunch from 12:45 to 1:30 and have the next set of sessions from 1:30 onwards. So we're running really out of time. So I would like you to be very brief in your questions and very brief in the answers. We still have 10 minutes. We can do 10 minutes, yeah. We can do 10 minutes, and we'll have 30 minutes for the lunch instead. All right, come to the mic. There's a microphone there. Keep it as brief, a short question and short answers. Yes, go ahead.
One is the patient
Is there a risk to the donor?
Yeah, so there's risk in every surgical procedure that we do, but the important thing to understand is that once you've been medically cleared to be a donor, there's no decreased life expectancy. There's no significantly increased risk of kidney failure. People live normal, healthy lives with one kidney, and I think that's that's the biggest take-home message that we tell patients. Obviously, there can be surgical complications, but that rate is extremely low, so it's very safe.
Okay.
Oh, yeah, what's the first question? I'm sorry. Oh, yeah, so so people are living longer, healthier lives. So both donors and recipients, we do not have an age cutoff. We look at everyone, individually. And so I think the oldest donor that we've done at my current institution was 79 or 80. Yeah. That's even older. I've done 5 patients, 84 recipient, but the donor was about 79, 80.
The recipient, he's done up to 84, he said, 84 years old to receive. But to give, you have to be a little bit younger. But he's done 79 before.
Yeah. Gotcha. Hard to say, but it's obviously, you need to make sure. Yeah.
That's a nephrology question. Dr. Mohitish, you want to answer that question?
Well, I think seeing a kid, even your primary care clinician doing a simple blood and urine test to see what your kidney function is a good idea. There are a lot of people who were impacted by COVID in terms of kidney function, so we recommend that to everybody. It's important to screen and all of that. Some studies have, yes, shown some long-term effects for some individuals, and some individuals had recovery, depending on underlying factors.
Okay. You have a question over there? Mm-hmm. Let me see the chart.
Hi, good afternoon. I've learned a lot today. Thank you so much, all of you. I wanted to know, Mr. Rang, what are you doing? What is being done for the providers to actually realize that some patients that do get acute kidney failure can end up with chronic kidney failure in the future, and to help prevent? This is personal for me. My mom had abdominal surgery last year for cancer and went into acute renal failure within 1 week. She resolved, but what happened was they never recommended her to follow nephrology, and now a couple of months ago we learned that she has stage 3 kidney kidney failure. But her PCP was good, as you said. They did give her a SGT1, I think, TL2 inhibitor, and it actually started to slow down the progression of her kidney disease. So my thing about it is, just like the providers they didn't do anything, they just left her alone because it resolved within 7 days. What is being done to actually make sure that the providers are aware that this is an issue, and when you have a patient that goes into acute kidney failure because of surgery, to actually have them follow a nephrologist so that they don't go into acute kidney failure? That was my first question. My second question is the gene that you talk about. Is it a regular blood test? How do you go about getting it? How do you educate the public to ask their providers to have the test done? And is it covered by your insurance? Is it a regular, blood test done? And do the insurance companies cover this? Because a lot of what I've realized is being a nurse for many years and being a nephrology nurse now is that a lot of our patients, education, they don't know the rights. They don't know what to ask for. Many of them don't know that that
Brief
actually that
question.
the
Question
doctor.
has to be brief.
I'm sorry. That they exactly what is being done actually in both scenarios to make the public and do the insurance cover.
Yes, thank you
That's
for
my
your
two
question. So in brief, for your question one, I would say that there's a lot of development in terms of improving the care for AKI survivors. There's a lot of post-AKI clinic that are actually being studied, NIH funded, and we're trying to prove that patients who are AKI survivors, after having survived episode of AKI in a hospital and getting out to the primary care and out in the outside of hospital, if they're being seen by a comprehensive care, by a nephrologist or by a nurse or by a pharmacist, the likelihood of them getting revert back to baseline creatinine is higher than having no follow-up. So there's a lot of literature surrounding that, and it's one of the initiatives by Kidney Health, KHI, that is trying to increase awareness of AKI survivors. And I think Dr. Marches will be able to answer this more in terms of follow-up care and how we can prevent the progression of CKD among Black patients. To answer your second question about NephroCheck. So NephroCheck is not approved to be used in an outpatient setting, as currently can only be used in an inpatient care. And inside a hospital, there is, regardless of your insurance, if the treatment team decided that a patient will be benefited from getting a NephroCheck test kit, that shouldn't be a burden on the patient side. It will be a burden on the hospital side.
Right.
And the cost associated with NephroCheck is actually currently kind of high. It's about $100-something per test kit. But I think it's because we don't use it often, so the cost stays high. If the demand is higher, the likelihood of getting this cost could be lower in the future. And also because we also use this kit among patients who I think we can be advocating for patients who are at a higher risk. So if we have a higher demand, I believe in the future we may be able to use this kit at a cheaper price, because the cost of someone who has ESRD.
Brief answers.
Okay, all right. Thank you.
Okay, Dr. Mohitish, you want to answer whether the test, the CKD screening is paid for? Who is paying for it, and what is it? Is it a urine test, blood test? What is it?
Yeah, sure. So I appreciate the question about APOL1, and I think there's a lot of different groups that are offering APOL1 testing. I can speak to where I practice at the Veterans Administration. It is free. I use my clinical judgment based on their family history and risk to test. There are some organizations who are offering free testing, however. So, I think it's something to have a conversation with your clinician about, especially based on family history.
Okay, we have a question over there. Brief question. Mm-hmm.
Good afternoon, everyone, and thank you for
It's
the
not a lecture, it's a
presentation.
question. Okay, good.
Yeah. My question is about the transplantation. I'm asking in a family where there is a genetic kidney problem, like polycystic kidney disease, is it a good idea to get a donor in the same family, like between close family or sibling? For a patient who need transplantation, or in other words, this transplantation may impact or may affect the survival after the procedure. Thank you.
I'll be brief. So what we do typically is just ensure that the potential donor does not have polycystic kidney disease, because it's not full inheritance. So just because one family member has it doesn't mean, let's say a sibling, doesn't mean that the other one will. So what we do is just ensure that donor doesn't have polycystic, and then it's perfectly fine. The other answer is that we want a living donor that's healthy, whether it's a family member, a friend, a stranger. So as long as they're clear, then it'll be fine.
Okay, Dr. Watson, I have a quick question for you. You had mentioned that the ATAP funding was cut or something like that. Are you still able to continue the study?
So we actually were part of the same consortium. So it was roughly 5 projects, I think, that were all defunded. We got defunded right when we were about to go live with enrollment, so we're on pause until we can get the funding to proceed, because I would like to do it in a research capacity. Worst case, we could still do the program without, with less fidelity, but I think that impact would be minimized. So my goal is to get the funding for the research coordinator, et cetera, so to still do it the exact planned way.
Okay, very good. Thank you. Yes, there's a question in the chat. Go ahead.
Hi, there's a question for Dr. Rung. As it pertains to hospital-acquired AKI, would a medication reconciliation be a therapeutic intervention that could help mitigate hospital-required AKI? If so, is medication reconciliation practiced at your institution, and is it a service provided by pharmacists?
Thank you. So as a pharmacist, we always emphasize greatly on reconciling the medication that the patient is using prior to coming, during the stay, and then when at discharge. There's a lot of quality improvement project that showed even AKI survivors, they are still discharged with 1 or 2 at least nephrotoxic agents. So at our hospital, we have an initiative to either reduce nephrotoxin burden on admission during AKI, and if it's not modifiable, we try to come up with a interchange that we can use that is less nephrotoxic. And at discharge, we have an initiative to also reconcile all the medication lists before we send a patient home to minimize the progression to CKD in the future.
Okay. I would ask Dr. Mohitej a question. You had mentioned that you had a Senate hearing following the withdrawal of those funds with your Community Advisory Board. What was the reaction of the Senate Health Committee members?
Thank you. We met with staffers for a few different representatives, including AOC, who represents the Bronx district. It was, I think, incredibly important for them to hear from patient voices. And our stakeholder board includes people from New York City, but also around the country, just to hear how much hope has been kind of almost stolen from them for new discoveries, and to hear about how much this is going to erode trust and continued, kind of clinical engagement and clinical trials. I think it was very powerful for all of us to be together in that space. What will come next, I think, is the biggest question. I know they were trying to hear from as many defunded investigators, and it was particularly important for them to hear the patient voice. So I encourage everybody who is in this situation to ask patients and community organizations to speak truth to what is really happening. We need more of our representatives to hear the profound harm that is being done.
Okay. All right, it's exactly 1 o'clock. So I want to thank the speakers for a wonderful job done, and thank you for coming for the conference.